are back for part 2 of our Hot Pearls from Disney World. Not sure if Matt has gotten any flu shots in yet, but my offer still stands to rescue his patients. And on this Labor Day, we also salute the comedy genius of Jerry Lewis, a hero to all lives touched by muscular dystrophy and other childhood muscle disorders. He's now reunited with Matt Helm. Rest in peace. Okay, Matt, take it away.
All right, so moving into yet another topic, because we're going rapid fire here. The United States Preventive Services Task Force, or the USPSTF, in a 2016 statement, clearly made an effort to let us know that it does not support screening for lipids in children under the age of 20. This task force cited a lack of evidence of the effectiveness of doing this. The UK also does not routinely recommend this screening. However, the National Heart and Lung and Blood Institute here in the U.S. does support routine screening of all kids between the ages of 9 and 11 years old, and again between 17 and 21 years of age. As we know, so does the Academy of Pediatrics. However, most pediatric caregivers in the U.S. do not do this.
I am not surprised that most pediatricians don't do this. I will talk about it, and I will get a screen. And the younger, 9 to 11, if there's risk factors. Mm-hmm. If the child's obese or big risk factors in the family. But I don't routinely get it, which is against the guidelines. And I was, in the beginning, I did it, and there were no big surprise. If a little bit high, it wasn't changing anything. And I always talk about exercise and good eating habits. I do usually get it somewhere later high school, college ages, and get the non-fasting, just total cholesterol and HDL if there's no risk factors. Often it's when I'm getting other blood work anyway. I'm getting a blood count in someone with menstrual issues, or I am getting a mono test on someone, and then I really try to throw in the cholesterol and HDL at that point. So I do the second one, but not the first one. I think that's a great thing for a future conference. That's a hot controversy. Should you follow these guidelines? Because I think, again, good physicians disagree, but I'm not convinced either by the evidence. What about you?
This is one that I've been torn on over the years. I feel like if I've taken a decent family history, I'm oftentimes aware of those kids who are at higher risk. Also, if there's a good social history, or for that matter, even an exam, as you said, kids who are obese, I'm a bit more concerned about. We have a couple of pediatric cardiologists in our community who are really adamant that this should be an important part of what we as pediatricians are doing as preventative care. And frankly, like some of the other screening things, I've really found it to be extremely low yield. And from the standpoint of practice, it's not something that we've really incorporated routinely into our practice. Now, because we seem to be at a point with a lot of the insurance companies, some of them now are using this cholesterol screening as one of their metrics in terms of rating us, and indeed in terms of our reimbursement. So even though some of us, and it sounds like Rob is one, and I certainly am one, do not necessarily agree that this is something that needs to be done for every single child, at some point the insurance companies have or will encourage us to do this, and the downside of it for us if we don't is it's going to affect our economics.
Right, and shouldn't be.
Right. That's a topic for another day. We could go on for an hour on that one.
Okay, next Pearl, I used the very next day when I came home. Came home Sunday, and the first patient fit this perfectly. Morning nausea in a teen that's not pregnant, that lessens over the day, is almost always a manifestation of an anxiety disorder. It coincides with a natural peak of cortisol in the morning, and it's often accompanied by headache and early satiety, meaning not very hungry, not hungry for breakfast. And when I have a teen come in, they're not having vomiting and diarrhea and fevers, not necessarily losing weight, but they're just nauseous in the morning, and it gets better over the day. I've had a few episodes, that first patient, but even since then, I'll just be able to kind of in my head go, okay, let's really make sure there's no anxiety issues. And you ask more questions, and bingo, it comes out. So I don't know if you've seen this too, this functional nausea, which is a real condition.
We see it constantly, not just functional nausea, but probably even more frequently, at least in my practice, functional abdominal pain. And so abdominal pain is a really tricky,
That's a huge subject.
Really tricky subject as it pertains to pediatrics, because at least everything that I've gone through in the literature will indicate that somewhere along the lines of 80% or so of abdominal pain that is long-standing, meaning it's going on for more than just several days or a week or two, really does largely seem to relate to somebody's mental health status, and most particularly with anxiety. And we find ourselves being in conversations with parents where parents, of course, the first place that their heads go tends to be, is there something anatomically or physiologically going on with my child? Do they have an ulcer? Do they have celiac disease, which is a hot topic these days? Do they have Crohn's disease? These types of things. And we also find ourselves giving respect to the parents' concerns and also not wanting to miss anything medical. But far and away, so many of these kids end up really having anxiety as either the source or as a major contributing factor to their abdominal pain.
And that's been something our whole career about, functional abdominal pain, anxiety and such. But this particular pearl about a nauseous teen that gets better, because we're seeing so much more anxiety, I am at least, as we talked about in the past few years. This very particular pool, you get a kid who's just nauseous and nothing else, your brain should be jumping into anxiety possibilities, although obviously not closing off others. But I thought that was something that now is way high on my radar screen.
There was one of the speakers made the point as we were discussing abdominal topics that many people now are using various homeopathic or naturopathic type of combinations for GI illness or for GI symptoms.
Functional dyspepsia.
Functional dyspepsia, right. One of these that was mentioned was Iberogast. And Iberogast is actually a combination of 9 different herbs. I don't happen to know what they are off the top of my head. But
reminded me of Kentucky Fried Chicken. Isn't like the secret recipe?
Right. There's a combination
of 9 different herbs and spices or something like that.
But anyway, so there are definitely ways to help to alleviate some of these abdominal complaints with kids that are a little bit outside of the normal thinking for us. Other things have been mentioned in terms of being helpful for this, including acupuncture and relief wristband. What do you think about acupuncture, Rob?
I keep an open mind. I think there's definitely studies show that it's helpful, and so you got to find the right person to do it, because I don't have any experience with that. So it's not something I use first line. It's usually like when nothing else is working. But every time I see a study, and I even go to talks, and they talk about how a lot of specialists have really found that it works, is very intriguing. I just don't have someone in our community that does it that I feel comfortable saying you should talk to this person. So how do you feel about acupuncture?
Well, I'm always really intrigued. It's one of those kind of internal controversies I have with myself. So, for instance, every once in a while I'll have something where my ankle will itch, and I'll itch my ankle and I feel it up in my shoulder. And I think to myself, wow, is this one of those like meridian things that the acupuncturists talk about? I do have a guy in my practice, actually he's a physician, originally a family doc and now an anesthesiologist, who actually became trained in acupuncture. And he said it definitely can give relief to people. I mean, he's a pretty open-minded, but conservative-minded guy. But what he found was that it's not typically reimbursable by an awful lot of insurers. That it wasn't really, quote unquote, something that was economically an advantage for him to know or to be able to do. And apparently he had invested quite a bit of money in terms of learning how to do it.
That's
right?
sad.
Yeah, it is, for sure. So moving along with another GI topic, stool calprotectin was a test that was brought up during this conference. And both this and a SED rate, or an ESR, are really considered to be excellent screens for inflammatory bowel disease. Rob, have you used this at all in your practice?
I have, and there's a talk by Dr. DiLorenzo years ago about this. And in my practice, I and my partners have had multiple teens, mostly teens, who have had all kinds of GI issues and weight loss and diarrhea, who have had normal SED rates, normal CRPs, no blood in the stool, and the only abnormal test was an elevated calprotectin, and they had Crohn's disease on Syncope. So I really believe in this test. Just Friday, for the first time, I had a parent tell me it wasn't covered well by their particular Blue Cross, and they had to pay over $200 out of pocket. That's the first feedback I got, which is very disheartening, because I think this is a wonderful screening test. It's going to be cost effective in picking up these kids early. So be careful about reimbursement, but if you're out there doing a workup for abdominal issues, significant abdominal issues, a stool calprotectin is a great test.
Yes. In fact, I think it's probably the only thing that I've considered adding to the usual tests that we'll think about when we're dealing with a child that we're really and truly concerned about their abdominal pain.
Right.
Yeah, at least the only new thing that I've considered within the last 10 years or so. Otherwise, the tests are pretty standard. So
babies 1 to 3 months of age cry about 2 hours a day, and at 4 to 6 months olds cry at least an hour a day. And some studies show that probiotics may help with quote-unquote colic. Also, spitting up in babies, young babies, is really common, and GE reflux is usually not the cause. So before reaching to prescribe antacids, do more common sense things. Avoid the seated position in babies around feeding. Make sure they're not overfed, and even breastfed babies can be overfed. If you think about it, a few-month-old baby getting 6 ounces of milk is like you or I getting 3 gallons of milk. And so the point was made that overfeeding is there more often, and also make sure there's no smoking exposure. And before you reach for drugs, if they're on formula, change the formula to a hydrolysate formula. Or if they're breastfeeding, stop all dairy before you reach for an antacid medication. And again, lactose-free formula rarely helps because lactase deficiency is extremely uncommon in babies. So I've changed what I do in the last few years, getting away from the ranitidine Zantacs of the world, and certainly PPIs, and we'll talk about, and trying to get more to the changing the formula or the breastfeeding mom's diet and smaller feeds at a time, and have really cut down the amount of medicine, Zantac especially, that I'm giving to babies. How about you?
Well, just to go back and comment for a second on the lactose-free formula, for a long time, this was one of the major niches of formula companies was lactose-free. Here's an option for you and your baby type of thing. And I think we may have touched on this a little bit during our discussion on milk and formulas. My understanding of this is that only 1 in 10,000 babies actually has lactose intolerance. Of course, that rate increases dramatically as childhood proceeds and even adulthood. But in terms of infants, very few have lactose deficiency. Lactase deficiency.
You can get short-term lactase deficiency with a lot of diarrhea.
Sure.
And that's a little bit different. Congenital lack of it is really rare.
Right. And so when a parent comes into my office with concerns about reflux, so many parents feel like if their baby is spitting some, that's reflux, and they've heard that reflux is a disease or that reflux is this extraordinarily painful situation. Really, for me, it comes down to 3 different things. I will say there's reflux, which really just means that something goes down and it comes back up. And then there's pathological reflux, which means that this is causing a problem in some way, shape, or form for your baby. And so the way I try to define pathological reflux really goes into 3 different questions. Number 1, is the baby gaining weight well, despite the spitting that they're doing or the vomiting that they're doing? Number 2, is the baby extremely uncomfortable? And by extremely uncomfortable, I mean not just the routine, as Rob alluded to, 2 hours or more a day of crying, but constantly uncomfortable, writhing in pain, unable to get any sense of satisfaction or rest. That, again, is a reason that I would be more concerned in a spitting baby. And then the third one is this a baby who is gagging to the point where they're actually turning blue with this vomiting, with the spitting? I tell parents red is fine. You and I will cough and we'll turn red. Blue is not fine. So those 3 criteria: weight gain, extreme discomfort, or having periods of blue spells with this. Outside of that, I tell people that this too shall pass. Get your spit wet rag ready. That's certainly what we did at my house. And that some of the other things Rob had mentioned in terms of positioning, et cetera, are all very helpful. So I'm sure we'll be touching on this a lot in the future, but that's kind of like my basic, Matt's 3 commandments, as it comes to sync up with Rob's process of describing things to parents.
Well, Matt, I have to say, beautifully put.
Thank you, man.
100%.
My audition's next week.
PPIs.
Yes. Proton pump inhibitors. So proton pump inhibitors, and we all know these more often by their brand names, and this includes Prilosec and Prevacid
and Nexium.
Yep, and there are certainly some others out there. I oftentimes have a really difficult time pronouncing the generics of these. But proton pump inhibitors have become oftentimes what pediatricians reach for when a baby is indeed terribly uncomfortable from what we're presuming is reflux. They're not without risk, though. And what are those risks, Rob Walter?
Well, the risks of proton pump inhibitors in all populations, I worry about more in the younger ones, is infection, things like C. diff and also pulmonary infections. There's also risks for bones and increased fractures from being on PPIs. In adults, it's been associated with dementia and even early death. So these are scary risks, and the studies show, especially in infants, that PPIs don't work at all. That multiple studies show that they don't work at all, yet the prescribing of PPIs in infants has gone way up in the past 10 years. And certainly the marketing of PPIs for infants by the companies has exploded also.
So do you prescribe PPIs?
Much less than I used to, and really almost never now for infants. I won't say I'll never do it. There's always some circumstances. I try not to make blanket statements, and I try to get them off it, but I don't use it as much as before. My partner, Dr. Aline, for older kids, gave me a little tip that she's found is something called apple cider vinegar, that you could put a teaspoon in 2 or 3 tablespoons of water, and she says it has worked great. There's something called Suja juice, Suja, which has this apple cider vinegar. I've never used that, but certainly any safe alternative would be helpful.
So raw apple cider vinegar or even pasteurized apple cider vinegar seems to be this miracle cure-all, especially in a lot of holistic communities and a lot of naturopathic communities. So patients of mine who have that bent or who are interested in pursuing those types of things will oftentimes comment to me that they used apple cider vinegar for this or for that. I've actually used it for molluscum contagiosum.
Really?
You can find it. It's in the local supermarket for maybe $5 or $6 for a big bottle of it. And since the whole point of largely our treatment of molluscum, which for those of you who are casual listeners are essentially warty little skin lesions, what the essence of trying to treat those is basically you're trying to alert your body that there's something that is not good for it in that area. And by putting a little bit of apple cider vinegar on that lesion, some people use acne medicines, but apple cider vinegar, again, is kind of more natural, as people seem to be obsessed with now. By putting that on the lesion, it alerts your body. It irritates it enough to alert your body that, hey, this is something that maybe I don't want to have around, and your body's natural immune system works to get rid of it. So I've had some success with that, and it has actually probably been one of the first 2 things that I'll recommend to people if indeed they're interested in treating the molluscum at all. But apple cider vinegar has been cited in use of everything from depression to stomach ills to dyspepsia, so it seems to be broadly used for any number of reasons.
I threw that out last second. We didn't talk about that. I'd never heard it before yesterday.
Really?
And obviously, it's a thing. One other thing to finish about PPIs is, and a point was made, which I probably don't make enough for my own patients, is that if you're on PPIs for more than a few months, you can't stop it cold turkey. Because if you stop it cold turkey, you will have a rebound hypersecretion, and all of a sudden your reflux will get a lot worse. So when you have patients who have been on it for a long time, you worry about fractures and infections, and you want to get them off it, and they tell you, but I stopped it, and my heartburn got terrible. Well, because you got to stop it really slowly. And I think that's probably the same even for young kids too who can't tell you. You can't just stop it cold turkey. You got to wean them down over a couple of weeks so you can prevent that. Because most of them can get off it, but you got to do it slowly.
The last thing I want to touch on with the protein pump inhibitors, this is really a pet peeve of mine, is that many folks out there don't realize that proton pump inhibitors are largely effective when they're used correctly and ineffective when they're used incorrectly. And so the correct way to use a proton pump inhibitor, from everything I'm aware of, is this needs to be administered somewhere in the vicinity of 20 minutes or so before a meal. 1 meal a day. These are once-a-day medications. And the reason for that is it actually has to be in the bloodstream when one eats, because it blocks the pump that pumps acid, the pumps that pump acid into your stomach. And those pumps can only be blocked when they're turned on. and they're typically only turned on when you eat. So it really needs to be administered about 20 minutes prior to the meal. I tell this to parents when I'm the few times that I'm prescribing this for their infants or for their older children, and the parents say, "Really? I've been taking this for years and I didn't know that." The same is true actually when we get to asthma or an episode on asthma. We'll talk about the fact that something like 80% of adults don't use their inhalers the right way. Mm-hmm.
I'm curious also, do all your parents sound like Elmer Fudd? Whenever you do it, parents like, really? I didn't know that.
Be very quiet. We're hunting Elmas.
Okay, so after the break, we'll be right back. Okay, a quick review of Disney World rides in 2017. I've been going there since 1973. And of course, Matt, why did you go to Disney World and not go to Disney World, Matt?
I went there to spend
with your
some
family?
time with my family.
They went to rides, but why did you go to Universal while you're staying at Disney World the whole time?
Well, back when we went to Disney World the other time,
you did go with your kids.
We did go once. So we waited until my son, who's the youngest one, was at least 6. That was kind of upon my insistence because I said, "Listen, I'll go once, but I can't promise you beyond that." So this was 12 years ago. We went. In that sense, I really felt like I'd done the thing. I'd done my duty as a father. And so this time around, when you had mentioned that there was this conference there, it was at the Grand Floridian, as you said. Very beautiful place. I have no qualms at all with it, except for I did find that when my kids had their wristbands that you can just kind of flash in front of anything and buy what you need that second. That gets pricey. That goes to your head a little bit.
They're like, it's free. Yes.
Like,
it's not. My kids are older. What would you do if you were in your mid-20s at Epcot at night and you had a wristband that gave you everything free? You would drink around the world, and that's the thing.
So I will admit to the fact that although we were there for, I think it was, 4 days, Rob? 5 days, something like that. We never stepped foot in the Disney parks. We spent some time at the pool at the Grand Floridian. Beautiful, very relaxing. Got some cold beverages there. And then we spent 2 days over at Universal Parks, and that was the plan. I'd never been there before, which not to my surprise, it was kind of just more Disney, but with different themes. To me, and this is just me, I certainly don't judge, but standing in a line for an hour and a half to go on a ride I really don't want to go on that lasts 5 minutes isn't really my idea of a good time. Yeah, I'm much more of a hanging out by a lake.
But it's Harry Potter. Did you go on any Harry Potter rides?
I went on that choo-choo train thing, whatever it was called. What's that called? Hogwarts Express.
Hogwarts Express.
Yes.
Did you go from one to the other? That's cool. That's cool. It's smart of them because you go on both and you have to pay twice as much money to go to both parks. But you didn't go the Hogwarts ride?
I didn't. The kids did.
It's really good. And then did you love Diagon Alley though?
I did think that was really cool, visually a very cool concept.
And of course, you had butterbeer because you can't go to Harry Potter World without butterbeer.
No way. That was on my do not drink list. Well, as somebody who really enjoys beer, I figured it would compromise any future experience of my taste buds. So I steered clear of that nonsense.
Oh, you're such a muggle. Well, quick review of the Magic Kingdom in Disney World. It retains its magic. The light and fireworks show on Main Street on the castle is my favorite part. And this year, Moana was added in all her glory, and it was wonderful. And for me, my favorite ride is the Haunted Mansion, which holds its charm 44 years later. There was a ride at Epcot that closed last week that my son and I got on before it closed called Ellen's Energy Adventure. It's the worst ride. It's cheesy, ridiculous, half an hour, starring Ellen DeGeneres, Alex Trebek, Jamie Lee Curtis, and a cameo by Kramer from Seinfeld. That's so awful that it's good. But it will be the site of the new Guardian of the Galaxy area with rides, which should be great. Really sadly, the Great Movie Ride closed also August 13th, which is a travesty. Got to go on it one more time. Wonderfully animatronic classic movie tour of The Wizard of Oz, Alien, Casablanca, Mary Poppins, and many more is now gone and gone forever. It's really sad. And lastly, the biggest new thing is the Pandora World of Avatar at Animal Kingdom, which is great, especially if you're into horticulture. It's really kind of magical at night. They have one ride, the River Journey, kind of a snooze, but the Flight of Passage, which is a 3D glasses experience ride that was really cool, that you go through a waterfall and you feel the water on you. You go underground, you can smell the dirt. The average wait was like 2.5 hours. We luckily got a fast pass because I agree with you. No ride's worth waiting over an hour for. It's supposed to be Disney's answer to Harry Potter World of Wizardry, and it falls way short for that. But the new Star Wars themed land is under construction at Hollywood Studios, and that should be spectacular. Also, Disney is coming out with their answer to Uber, which are called Minnie Vans, that have all polka dots and be just like Uber, and hopefully you could take it to Universal, because that's why I use Uber when I'm at Disney World, to go some time in Harry Potter.
You mean Minnie Vans like Minnie Mouse?
Like Minnie Mouse. So Minnie Vans, Minnie.
They're so clever.
Is that cool?
They're
I thought so.
Clever.
So any of you out there, we will be back. Hot Topics Pediatrics, July 26th to 28th, 2018 at the Grand Floridian. And again, send your comments to us, podcastpediatricians.com. If you have any ideas or suggestions, and go online to our website. Hopefully out there, you fellow pediatric caregivers have gotten their flu vaccines. We've gotten our adult flus. We're giving out a lot of it. How about you, Matt?
I don't think we have any of that yet.
You don't have flu vaccines, so any out there?
Oh, for goodness sakes!
In this area,
like, August what here?
If you're one of Matt's patients in this area and you want flu shots, come to my practice. We'll take care of you.
That would certainly be the...
We love children, and we want to keep them healthy.
The fact that Rob's practice has flu vaccines is probably the only reason you would want to transfer.
But what a good reason. All right, we'll be right back.
Look for the bare necessities, the simple bare necessities. Forget about your worries and your strife. I mean the bare necessities are Mother Nature's recipes that bring the bare necessities of life. Wherever I wander, wherever I roam, I couldn't be found out my big home. The bees are buzzing in the tree to make some honey just for me. When you look under the rocks and plants and take a glance at the fancy ants, then maybe try a few.
You eat ants?
You better believe it. And you're going to love the way they tickle. Mowgli, look out! The bare necessities of life will come to you.
But when?
They'll come
And
to
we
you.
are back.
There's been a 4-fold increase in the incidence of dogs with marijuana intoxication in Colorado since recreational pot was legalized, and 2 dogs died.
Oh, so what kind of implications does this have for babies, right? Who put everything in their mouths?
Exactly. And there's something called cannabinoid hyperemesis syndrome, CHS, that can affect regular users of marijuana with early morning nausea, hypervomiting stage, and these adults and teens often will have normal gastric emptying compared to cyclic vomiting syndromes, where that will be delayed. A very, very specific history point in this cannabinoid hyperemesis syndrome is that they'll tell you that hot showers or baths give them relief. This condition is often misdiagnosed for a long time, and the clue can be when they say, only thing that helps the vomiting is getting into a hot shower. We see more and more potheads in college, and we'll do another episode on recreational pot, legalization, and that whole morass, but I think it is a problem.
So another point that was made was catechins.
Is it like catechisms? You're Catholic.
I am.
Maybe it's
well, my bent was to say catechisms. But catechins in green tea may improve cognitive function in Alzheimer's and in Down syndrome. So do you drink green tea, Rob?
Occasionally.
One of my goals is to actually drink more green tea and perhaps less coffee, because coffee is, as a couple different studies have shown now, does have some medical advantages. But green tea has some other advantages, just one of which now appears to be improving the cognitive function in people with Alzheimer's and with Down syndrome. So another quick pearl, early introduction of glutens into a diet, whether it be into an infant's diet or a young child's diet, does not prevent later celiac disease. There's no window of tolerance here. Breastfeeding does not seem to affect the chance of getting celiac disease. So this goes, having spoken already about peanuts and now about eggs, it would appear that introducing glutens does not have any protective effect or harmful effect. The incidence of celiac disease in the sibling of a celiac child, a celiac sufferer, is about 15%. So relatively high risk there. However, it's 85% in an identical twin. So twin studies are fascinating, aren't they? So,
Yep.
So in evaluating high-risk children, if an HLA-DQ2 and an HLA-DQ8 are both negative, so these are the two alleles, I believe that would be the right word, tested, it virtually excludes the possibility of celiac disease ever. However, if one or both are positive, then it's wise to do a celiac IgA TTG test every 2 to 3 years.
And that does come up. And if there's a high-risk
certainly
kid,
does.
get that DQ2 and DQ8 negative. See you later, all good. Positive, you should retest every few years to see if they have celiac. Epilepsy is defined as 2 or more unprovoked seizures. If you have a first unprovoked general seizure, a good history and a good physical and an EEG is usually all that's needed. If it's a focal seizure, consider an MRI also. Absence seizures start usually after 4 years of age. It's not just staring. There's complete behavioral arrest. And finishing spells, breath-holding spells, are benign and need reassurance only. But if they're particularly striking, and sometimes they are particularly striking, it could be reasonable to get an EKG to rule out prolonged QT syndrome, and even an EEG if there is particularly long loss of consciousness. And lastly, stereotypies of hand flapping, sometimes head banging, rocking, nodding, especially when excited, is completely normal, even though they're more common in kids with autism. Most kids with stereotypies do not have autism.
To comment on one of the things you just said, so I have at least one patient who has had absence seizures prior to the age of 4. So they do exist. They're just not nearly as common. Moving right along with neurologic kind of stuff. Tics, so little muscular twitches, they tend to peak at 11 to 13 years old. More males than females. And what this is really a frontal lobe disinhibition. So there's also an increased risk of ADHD, OCD, and anxiety in people who have risks, and vice versa. So somebody who has ADHD has a higher risk of having tics. We will definitely touch on this topic when we discuss ADHD. But what one of the speakers made clear was that cognitive behavioral intervention therapy for tics is CBIT. This type of therapy can actually really help. So there are means of trying to correct these things outside of the medication, which oftentimes has side effects that are unacceptable to the child or their parents. Stimulant medications people have in the past equated with an increased risk for tics. As we have been taught by the neurologists in our community at least, and I think this is just general knowledge, stimulant meds, so things like Ritalin, any type of methylphenidate, et cetera, do not cause tics. However, what they do end up doing is unmask a predisposition for having tics. And so we do see some of the kids in our practices who are on these stimulant meds start to have tics. And then it's a bit of a dilemma for us as to whether or not we should address that aggressively or not.
I certainly get neurology involved.
Yeah. In that situation, we oftentimes will punt to neurology. Moving right along with one more neuro bit here. So migraine headaches. To prevent migraine headaches, one should consume their weight in pounds in ounces. So for instance, if somebody is 80 pounds, they should consume about 80 ounces of water per day, or of fluid that's non-caffeinated per day. Also, exercising 5 times a week tends to help to prevent migraine headaches. Good studies show this. And of course, good sleep hygiene, which to me is probably one of the very most important things outside of hydration in terms of preventing migraine headaches.
And more on migraines, and just to say the 100-ounce max of fluids is more than I was doing. I was doing like 64 or so that was kind of eye-opening. And I've kind of, when they're 100 pounds or more, they can get up to 100 ounces of water a day. Another point, I have a little handout about migraines, but they talked about using a written headache prevention and treatment plan like we do for asthma action plan, have a migraine action plan, which includes Ibuprofen, 10 per kilo, right away if you get the headache, but no more than 15 days a month to avoid a medication headache. Includes giving 10 to 12 ounces of Gatorade or Powerade right away, but not G2 or Propel or artificial sweeteners, and to immediately do as appropriate a triptan. And the recommendation was to go to the nasal sumatriptan as a first line. And you can use this up to twice a week. They also put these migraine-prone, mostly teens, on Riboflavin B2, 200 to 400 milligrams per day to prevent migraines, and you could take that forever and just warn the teen that it could turn their urine orange. And also talked about CBT, cognitive behavioral therapy, for some teens with migraines.
So the nasal sumatriptan, I'm assuming, is recommended as a first line because it's more easily absorbed, I guess?
It works faster and it's easier absorbed, and again, this one person said it just works the best for his patients. So I had not been using that as much. I was using the pills and such, but I have given the last few kids with migraines prescribing the nasal.
Smart. I don't understand the G2 or Propel avoidance, although I understand the artificial sweetener avoidance, so I'll have to look into that a little bit more. Do you have this made me think of when somebody calls and asks you, I'm a breastfeeding mom, I want to switch over to formula, where should I start? How much should I give them? Because I was taught a little rule way back when about this. I'm not sure if you know this. So suppose somebody calls and says, okay, my 2-month-old, there's just no way I can continue to breastfeed. I want to switch them over to the formula. How much should I offer them at a time? The rule that I know is if you take the baby's weight in pounds and divide it by 2, that's usually how much the baby can comfortably tolerate in ounces, plus or minus an ounce. So it's usually a good place to start. Did you know that?
I did not know that.
I knew something else that you don't know. Okay, so hips. Let's talk hips. To prevent developmental dysplasia of the hip, or DDH, hip ultrasound should be done at 4 to 6 weeks for risk factors, especially if a child is breech in the 3rd trimester. Later on in infancy, the Ortolani maneuver, and the Barlow maneuver, which I always remembered as I was trying to teach medical students and residents. So Barlow means back. So essentially, you're trying to dislocate the hip with the Barlow maneuver. You're grasping essentially the knee and gently pushing backwards to see if you can dislocate a hip.
As you adduct.
That's right. So B, Barlow, back, and then Ortolani, in which case you're actually trying to replace a already dislocated hip into the acetabulum, and you're bringing the knee kind of in and up toward the midline. Ortolani, I remember by other. So there's Barlow, which is back, and Ortolani is the other one. So these are not as sensitive. These two maneuvers are not as sensitive as decreased abduction of the hips
when you get into later infancy.
Right.
And DDH. My first paper I ever wrote was on DDH. It's dear to me, this subject, and it's one of it's either number 1 or number 2 in all studies of medical malpractice pediatricians. So it's really important for pediatricians, other pediatric caregivers to document the exam. Also, as they start to walk, document their walking on your exam. And there's other couple little tricks, like if you hear unilateral toe walking, my child walks just on 1 foot toe walking, think, could this be hip dysplasia? The early ultrasounds, you don't want to do it too early because you get false positives. So 6 weeks about the sweet spot. And you want to go to a place that's good. And we're lucky to be near a children's hospital, which is like the leader in the country in hip ultrasounds. They teach the rest of the country.
What's your sense of using asymmetric leg folds as an indicator?
I do, when they're obvious, send them, but they're usually normal.
Right.
If the hip exam and the Galeazzi exam, when you're looking to see if the knees line up when they're flexed, if one's dislocated, they won't line up and one knee will be higher than the other. So I find they're normal. So if it's just really mild asymmetry, I don't send them if everything else is normal. But if they're really asymmetric, I send them, and they're always normal.
Like you, I for a while was doing it, especially for the more overt ones, and hadn't had any positives. And so I'm a little bit less eager to send those kids along for hip ultrasounds at this point. Mm-hmm. Moving on to hearing. So unilateral, one-sided hearing loss seems to hurt language development. There's now good proof that this is the case. just one functioning ear is really not optimal, is really not good enough. We used to be told that, hey, as long as they can hear out of one side, then everything's good.
It's good enough. It's good enough. No,
so
it's not.
in terms of both language development, and we just had one of the area specialists come to speak with us about not just language development, but overall well-being, things like coordination, things like, kind of locating one's place in the world from a proprioceptively, all that type of thing. Very important to have both ears. There's a reason for that. And so if there's a risk, or if there's a chance that a child is not hearing adequately out of the other ear, this really needs to be addressed sooner than later.
And also, any hearing loss in newborns must be confirmed with an ABR and intervention starting before 6 months of age. So that's what the whole push is for early hearing tests in the newborn nursery. And if there is hearing loss, everyone should get a genetic consult, because there's so many genetic syndromes associated with hearing loss. A newer thing we just started in our hospital is that if the child doesn't hear, then they get a CMV, cytomegalovirus PCR test for all of them. And if those are positive, to get an infectious disease consult quickly to see if early treatment can be helpful, since CMV is a lot more common than we pick it up, and hearing loss is common, and you can do something about it. So this is something I think most of you out there are going to start seeing more and more about CMV tests. The scary part is also not just hearing, but brain issues and microcephaly and calcifications in the brain. Most of the CMV kids are asymptomatic, but we probably need to be much more aggressive looking for a problem if the child is CMV positive. Variable strabismus is not normal after 4 months of age. This comes up all the time where the parent says their eyes are not always looking the same way in a young infant, and you look and they're pretty symmetric in the office and the red reflex is fine, and we tell them, well, it's common in the beginning to be a little bit off and we'll watch it, but after 4 months of age, you probably should say you need to see the eye doctor. And 2 common congenital strabismus syndromes were noted. I've had kids with both of these. I don't know about you. One is Duane syndrome, where the upper lid retracts and that eye turns in when they move side to side. It's not pure sixth nerve palsy, because with pure sixth nerve palsy, there's no retraction of the lid. And Brown syndrome, which is the inability to elevate the affected eye when it's adducted or look in. So the baby looks in and up, and the eye they're looking in that direction goes up nicely, but the affected eye just stays downward, so it looks really freaky. It's just congenital. There's nothing to do about it, but it's something that I think we should be aware of.
Yeah, I've not had any patients with Brown syndrome, although I have had at least 3 with Duane syndrome. And it's interesting, the way it presented to me initially was the parent was concerned that the child was crossing their I believe it was their right eye into the middle, and they kept doing that, and they were worried that their right eye was crossed. What was actually happening was they were looking to their left, and their left eye wasn't able to look to their left, only their right eye was. And so it's presented as a problem of cross-eyed, and what it ended up being was actually the eye that wasn't crossing was the eye that was affected. So I think a couple of years later had sent another patient to the local ophthalmology group and said, I'm concerned about Duane syndrome. And the ophthalmologist said, how the heck did Matt know about Duane syndrome? It's so rare. And that goes back to what I said a little while ago, which is, one knows what one sees. So it was something that I was already familiar with, and made me look like I knew what I was doing, at least for that. There are myriad of things that I've been stymied on over the years, but that was kind of like a coup for me. Like, oh my goodness, I knew that one already.
So they basically said, how did Matt know this?
That Matt? Right?
Sure?
The Matt I know?
You sure it's not his partner?
Right.
So football, flag football is way less dangerous for serious injuries than tackle football, but the overall number of injuries is actually more than tackle football, and it's mostly from finger injuries, especially if people play with belt loops. So if you're going to play flag football, wear pants without belt loops. Also, a point was made that college football was brutal and way more lethal in the old days. Between 1900 and 1905, 45 college football players died from acute injuries playing football. They made a lot of rule changes, and then Teddy Roosevelt actually stepped in to save the sport of football, because there was a big movement to outlaw football. which mirrors what's happening today.
Doesn't it?
About should we get rid of football, especially the recent CTE findings. I think 111 out of 112 football players that were positive. So this will be another podcast, and maybe at Florida next year, about should you tell your moms if they ask you, do you think you should tell them that their child should play football? And what should pediatric caregivers say about their own kid? Some may say, yeah, it's okay if you're careful, but not my kid.
Yes, this is such a fertile ground for discussion and for controversy, but astounding. So you said between 1900 and 1905, 45 college players.
I mean, it was brutal. It was just like kill the person with the
being
ball.
A gladiator, right?
Exactly. It was the old Roman times.
Wow.
I do think 2 points. One is that the better the helmets, the more injuries, because people lead with their helmets. So the old leather days probably was better than these unbelievably huge helmets. And the other is that we should be tackling like rugby. In rugby, which is a really cool sport, much less these injuries because they tackle in a way that really doesn't promote head injuries. And I'm hoping more and more rules will go out to make sure people in football tackle like they do in rugby.
Yeah, that definitely grounds for a great deep discussion in the future on one of these podcasts.
Especially since we're both sitting here wearing Philadelphia Eagle shirts.
Right.
So it's not like...
yeah, we're football fans, and so we're really torn
yes.
right down to our core.
Yep.
So moving on, let's talk a little bit about cystic fibrosis. So what we had learned at the conference was that apparently the composer Friedrich Chopin... Oh, nice. You're all queued up. Nice, Rob. May have had cystic fibrosis. Another point that was made about cystic fibrosis, which was kind of disturbing to those of us in the U.S., is that Canadians with cystic fibrosis have a 44% chance, actually a 44% lower risk of death than U.S. citizens with cystic fibrosis. So the average Canadian with cystic fibrosis lives about 10 years longer than the average American with cystic fibrosis, and they live to an average age of about 50. The difference is, or seems to be, mostly in the U.S. with patients who have Medicaid. Interesting. So Medicaid versus socialized medicine. So no difference with cystic fibrosis in those in the U.S. who have private insurance. Access to lung transplant is also a big factor. What was that piece called? Classic.
I don't know.
You don't know. That's why I called you out.
It's like most popular Chopin. There was talks about irrigating ear canals and removing wax, and you shouldn't do it unless the child has at least 18 months out of their ear tube falling out. And obviously, just listen to our podcast on earwax is lit, and you'll hear everything and more that you want to know about earwax. They also mentioned about that thing that Matt mentioned, that cognitive delay and intellectual disability does increase the risk of excessive earwax.
But why?
I don't know.
Gosh,
don't know.
That's a mystery.
No. Cardiologists talked about cardiovascular risks and total sugars, which are naturally occurring sugars in edible products, as opposed to added sugars, which are used in processed foods or added separately. And that added sugars increases cardiovascular disease risk. And children under 2 should not get any added sugars. And older children should get no more than 25 grams per day, which is 6 teaspoons of sugar. And as a note, and Matt and I have talked about this, it's come out that in the 1960s, Big Sugar bribed their way into not getting blamed for heart disease along with fat and cholesterol, and that sugar should be right up there with fats as possible risk factors. And now we know the truth was always out there. And then there's salt. The point was made that salt intake shouldn't be more than 1,500 milligrams a day, but most Americans get over 3,400 milligrams of salt per day. I will say there's an alternative side to this that wasn't brought up, that some people feel that too low of a salt intake can be unhealthy. So as with everything nutrition, it gets really confusing. The amount of salt in lasagna in a popular restaurant chain was over 2,500 milligrams, which is way more than the combined salt in a large French fries and quarter pounder at McDonald's and a few other things. So beware of lasagna at chain restaurants. And Matt, they talked about the 6 most common high salt foods, which are...
Yeah, so some of these are surprises and some aren't. So bread and rolls, who knew, right?
A lot of salt in bread.
A lot of salt in bread, right? Which probably is part of the attraction for people.
Right.
Cold cuts, cured meats, not a surprise. You know,
Nope.
that I think we knew. Pizza, okay, if you think about it.
And you eat a lot of pizza.
I don't eat that much.
Every time we go out, you have a pizza.
Well, last night I had pizza for dinner.
Yep.
Yeah. I do some healthy things too. And then poultry, which I'm not sure exactly why that is. I think that, a couple of, when we were talking about this before the show, number one, perhaps it's the way it's prepared.
Right.
Salt's oftentimes used, and especially in chicken that is acquired. For instance, you get your rotisserie chicken at
I love rotisserie chicken.
At Boston Market or at Costco or wherever else you
Giant.
shop. And also, I think, and I can't be sure of this without looking into it more deeply, but I believe that some of the major producers of chicken actually infuse the chicken breasts with a saline solution to kind of plump things up.
I think so too.
Yeah. So soup.
That's a huge one. Read the labels on
Huge.
soup. They all have like 800 milligrams of salt.
Yeah, and sandwiches, which also makes sense because I think a lot
bread.
of times sandwiches, both the bread and the cold cuts, right?
Right. Now, a talk was done about orthostatic intolerance, and there's so much in there, and it's such a big subject. We're going to have to talk about it, but it breaks it down into neurally mediated syncope, which is what we think of as vasovagal syncope, and also you can put breath holding in there. 1% to 6% of all hospital admits are on the syncope. 1% of ED visits. It costs billions a year. A second category is POTS, postural orthostatic tachycardia, and a third is rarer is the orthostatic hypotension from neurogenic conditions like Parkinson's. But syncope is an abrupt loss of consciousness with decreased tone. There could be prodromes of pallor, sweating, nausea, abdominal discomfort, yawning and sighing. They may be hyperventilating, and they'll often say, everything's getting dark, I'm getting tunnel vision, I can't hear. Really, a good history and physical exam is usually all that's needed when it's clear. If they were in church, in a really hot church all morning, and sometimes if it's impressive, I usually get an EKG on kids who have real syncope. And again, triggers can be pain, emotion, exercise, defecation, coughing spasms, even laughing, and you try to avoid these triggers and hydrate.
Yeah, a lot of what we see in the office in terms of people who are calling our office for what seems to be a very urgent and concerning problem is indeed for syncope or fainting or near fainting. And it's not uncommon for these kids to have really a pretty typical body habitus sometimes. They're oftentimes tall, thin kids. I think you had made a point about, speaking of tall, thin, made a point about how amazing giraffes are.
Yes, giraffes are cool. They made could you imagine how tall they are? So how do they keep their brain, when they're standing, how do they keep their brain with enough blood? And then when they eat from the ground, how come they're not just collapsing from all the blood going out? So yeah, anyway.
Right. It was fascinating physiology there.
Yeah, they have veins that pump the blood much more than we do to make sure that their blood pressure stays the same. So yeah, I didn't think you were going to bring up the whole giraffe thing.
Well, I thought it was kind of cool.
It was really cool. They had a little video on someone named Professor Sutton, who was really droll, very British, about that you should tell patients who have a predisposition to syncope.
Wait a minute, you're not going to do this in a British accent?
I can't do a British accent.
You said you were. Come on.
I could do the Harry Potter. She needs to sort out her priorities. It was Hermione talking about Ron, I think, but I really can't do it. I always sound like Julia Child, like, so. But if they feel like they're going to have syncope, then they should sit down or lie down. And you should tell your patients to do isometric exercises like linking their hands together and pulling them apart, which will increase your blood pressure by about 30. You can also tighten your legs against each other while sitting, which will also increase your blood pressure. Then, of course, you can get into the reverse Trendelenburg position with your legs up, but Professor Sutton cautions that you should not do this if you're a woman wearing a skirt. It's kind of sexist, but it was this old video of a British guy. It's actually kind of funny.
So one thing that we do know about syncope for sure is that we should avoid using beta blockers in kids with syncope. Just not a good idea. The cardiologists feel very strongly about. But when we go back to some of the subsets of syncope, think of POTS. If heart rate goes up over 30, by over 30 beats from what its baseline was when standing with no significant change in blood pressure. POTS patients oftentimes are slender females. We talked about this a minute ago. That seem to be, sometimes anxiety prone. That seem to be perhaps they're a little bit sickly. The dizziness may be constant. Also, they can have breathing issues, chest pain, palpitations, abdominal pain, fatigue. So these are some of the ways that POTS presents itself as a subset.
That's a lot of things. And, we can't get into the details of POTS. It's such a broad category and frustrating category. Around us, a lot of the kids who get diagnosed with POTS end up, at least for me, at CHOP or the Mayo Clinic for extended periods of time. And this deserves its own episode and probably lecture in Florida. And perhaps by neurologists, too, because I think cardiologists and neurologists have a different take on this. But, in adults, up to 25% of adults become disabled. And in the pediatric age range, people diagnosed with POTS often end up homebound, schooled for a long period of time. And it can be associated with autoimmune diseases, Ehlers-Danlos, eating disorders, acute deconditioning, something called median arcuate ligament syndrome. It is a real complicated subject. The neuropathic POTS, which is the most common subtype, often have a purplish hue to their legs upon standing, and the treatment can include TED hose, leg elevation, increased water and salt, plus exercise. And I find in all these conditions, getting them moving, physical therapy, exercising is the key.
Yeah, I had a patient once, really, really dramatic, who, if she was touched and she wasn't expecting it, she would faint. And we were told that was one variation on this theme. And in fact, one day in the office, I went to examine her and just put my stethoscope on her, and she bonk, like completely lost consciousness. And I kind of felt like King Midas, but with the I make you faint. That's right. I don't turn you to gold. I make you faint.
Everything I
really
touch turns terrible.
Shocking. Yeah. So tough one.
It is a tough one. And there's also hyperadrenergic POTS that have a high baseline heart rate, and then they go even higher when they stand up, but their blood pressure doesn't go down. They seem to have an increased sympathetic nerve activity. So again, it's a complicated thing that you're going to get specialists involved also. And the last pearl that was given was about garlic breath. Do you remember that? Were you paying attention for that?
I was, and it was particularly germane because I like my garlic.
So garlic breath, people think, garlic breath, you have garlic in your mouth, but actually when you have garlic breath is when you eat garlic, it gets to your gut, it gets absorbed, it goes to your lungs, and you exhale breath that has the garlic odor in it. So it's really in your breath. So that's why breath mints in your mouth won't really help when you have garlic breath. And a researcher actually did studies where he ate garlic and he ate all kinds of food to see what might decrease the garlic breath. And the two main ones were a fresh apple and lettuce. So that's why when you have a Caesar salad with lots of garlic, you usually don't get garlic breath because the lettuce blunts the absorption of the garlic. Who knew?
That to me was one of the key pearls of this conference.
Really cool. There'll be one more episode of season 1, which will just be a recap, which we're going to talk about all the other episodes and new data that came through and some feedback we got beginning from sleep from episode 1 to here.
Sounds great, Rob.
Say goodnight, Matt.
Good night, Rob.
Good night.
Everybody wants to be a cat, because a cat's the only cat who knows where it's at. Tell me, everybody's picking up on that feline beat, cause everything else is obsolete. Strictly high button shoes, a square with a horn makes you wish you weren't born. Every time he plays, oh, a rinky-tinky-tinky with a square in the act, you can set music back to the caveman days.
Oh, a rinky-tinky-tinky. Everybody wants to be a cat,
Because a cat's the only cat who knows where it's at.
When playing jazz, you always has a welcome mat.
Cause everybody thinks a swinging cat. Oh boy, fellas, let's rock the joint. Groove it, cat.
Podcast Pediatricians Productions. All rights reserved.